We're now in the virtual world, and we have two presentations, one on the virtual ward and the other on virtual rehabilitation. Thank you for answering the poll. I see that large numbers you were involved in video and teleconsultations, and smaller numbers with virtual wards, pulmonary rehabilitation and telemonitoring. But let's go to our first presentation, and I'm really glad to introduce Dr. Sarah Sibley. She's going to speak on lessons from the virtual ward, from the management of COVID-19 patients in virtual wards, but also its relevance to other non-COVID situations, exacerbations of chronic lung disease, for example. Sarah is a consultant respiratory physician at the Liverpool Heart and Chest Centre. She's a lead in respiratory medicine. She's worked extensively within the community and also with virtual wards during the pandemic, and so has great experience in this area. So thank you very much, Sarah.
Thank you very much for inviting me to come and speak today about virtual wards. I'll just wait for my slide deck to appear on screen. It's been an incredibly difficult year, and it's really great to see that we're actually getting some learning from the virtual wards that we've developed over the COVID pandemic, and I can see that this is going to start to transform the future of care for respiratory medicine. So some positives out of what's been a really difficult sort of year that we've had to all endure together across the world. So just a little bit of background about where I'm from. So I work in England, and I work in the northwest of England. The red bit on the map is sort of where I'm working at the moment in Cheshire and Merseyside. We have a population of about 2.5 million people, and it's an incredibly diverse population. We've got beautiful city, which was the European City of Culture a few years ago, Liverpool. We've also got beautiful rural countryside and a lot of affluence. And we've also got vast numbers of our patients living in absolute poverty, in sort of horrible situations. A lot of people live in the sort of lowest 20% of the demographics in the population in abject poverty. So we've got a real variation of population that we serve where I work. So hopefully what I talk about will be relevant to people in all different settings across the country, across the world. So COVID virtual wards and COVID oximetry at home were developed at pace in England, and we started to look at oximetry in a home setting because very early in the pandemic we realised that it was hard to know who should present to hospital at what time, particularly because of silent hypoxia in COVID. There was some research done quite early in the pandemic that found that oxygen saturations at the time of presentation to hospital were a real marker of how actually people were going to recover from their illness, or whether actually they might die within the hospital. So quite early on we realised there was this link between oxygen levels and clinical outcomes. So lots of different areas across the country started to work on measuring oxygen saturations in the community. And really we had a whole revolution of care grow within England over the pandemic period. I will share with you, just while I'm waiting for my next slide to appear, some research that was published today, which has shown that if you were on a COVID oximetry at home service, you had a 6% mortality in hospital versus people that were not on a COVID oximetry at home service had a 20% mortality in hospital. So that's really quite compelling evidence as to why knowing your oxygen saturations in the community have been so important. Is it possible to move on to the next slide, please? Great, thank you. So we developed in England some pathways for patients who were in the community with COVID to really measure their oxygen levels at home, but also let them know at what point they should seek help. So we had patients with oxygen levels that were normal, so 95 to 100 were advised to stay at home. People with very low levels, and 92 was the cutoff from the evidence on the slide that I presented previously. 92% people should go directly to hospital. And if saturations were 93 to 94%, they should seek medical care. This really enabled a sort of widespread triage system within the NHS and allowed all healthcare professionals across the whole system to be following a similar pathway. So we had to ensure that people across primary care, ambulance services, emergency departments, the whole of the system were following the same guidelines, which was no easy task in the pandemic. This then moved on to, well, what happens when people present to hospital? So again, it was a similar triage system that if people had good oxygen levels, no desaturations, they could go home and be monitored at home on an oximetry at home service. If their oxygen levels were moderate, they had further investigations and may need treatment. And if their oxygen levels were low, they needed admission to hospital. The onset of using COVID oximetry at home and COVID virtual wards meant that when they were implemented in the UK, which was around sort of late autumn last year, we saw a significant reduction in length of stay within the hospital, and we saw lots of short lengths of stay, which is what we wanted. So people were presenting at an early stage of their disease, and then they could be assessed in the emergency department, maybe in hospital for 24 to 48 hours, started on treatment, and then discharged from hospital into a virtual ward model. Can we go to the next slide, please? Thank you. So we had two systems that developed in England over the pandemic. We started with COVID oximetry at home, which was a primary care supervised service for the vast majority of patients with COVID who were at risk of deterioration. So we offered this to people who were initially over 65, and we lowered the age range to over 55, or people that had healthcare conditions that made them clinically extremely vulnerable. They were offered oximetry at home, and they were given clear advice and education about how to self-manage their condition. So this was really a self-management tool that we told people at what point they should be calling for help and how urgently they needed to call for help. We educated them about silent hypoxia and that they shouldn't ignore their oxygen saturations. This grew over England at a very rapid rate. We developed COVID oximetry at home services all over the country, some of them supported by telehealth and digital tools, some of them supported with just paper diaries. So there was a whole range in the sort of technological abilities that we used to support this. As that was embedded across the country, we then developed COVID virtual wards, which was a sort of for the higher end, more complex, acutely unwell patients. So these were people that had been into hospital. They were supervised by a consultant who was experienced in managing COVID, and it allowed us to be able to discharge people home a few days earlier from their illness than we would have done otherwise. We were able to send home patients who were still taking dexamethasone, people who were still on oxygen, and we had you had confidence that they were going to receive a good level of care at home, just as they would in hospital, and it enabled many people to be discharged from hospital at an earlier point across the country. So just to give you an idea about how unbelievably rapidly things can be implemented, you wouldn't have believed this before COVID. I'm still staggered by it, really. Initially, things were just growing up in small parts of the country, and then in November, the NHS recommended that all areas should have an oximetry at home service in place. And we really went from nothing and little tiny pockets of innovation to, by February, 100% of the country had COVID oximetry at home and COVID virtual wards established and running, with hundreds of thousands of patients being onboarded onto these services, which is staggering. It was a real movement in the country. Can I go on to the next slide? Thank you. So just to give you an idea about the criteria again, we use the same criteria for both oximetry at home and COVID virtual wards. We try to keep everything very clear, very simple. So if your oxygen saturations are 92% or less, you should be in hospital. You shouldn't be discharged. If your oxygen saturations were 93 to 94, people who'd been in hospital could be considered for early discharge onto a virtual ward, and if their oxygen saturations were 95 or higher, they could definitely be considered for discharge. Many patients were discharged from hospital without going onto a virtual ward, but the virtual ward was there for people who perhaps still needed dexamethasone, were still quite unwell and needed a bit of extra clinical supervision, or people who required oxygen to keep their oxygen saturations between 93 to 94. I'm not going to go through this, but it will be in the slide deck if anybody wants to go back and look later. This was the detailed discharge criteria used across the country for COVID virtual wards. And it was really vital for us to get the criteria right. So I'm going to talk a bit now about the local experience of the COVID virtual ward that I was involved in. I work for Liverpool Heart and Chest, and we provide a community respiratory service for our local area, which includes a local district general hospital called Wiston. On the far left of the picture were the people that really led the virtual ward within the hospital. So we had a nursing team from our hospital, we had the head of emergency medicine and the head of acute medical admissions, who all worked together to implement this within the hospital. We then had a team of people who worked outside the hospital to actually look after the patients when they went onto the virtual ward, which are kind of the middle pictures. And then we had at the far right, you can see on here, we had a acute response team, which included the ambulance service and respiratory clinicians who could go out to see people at home if they were unwell. And one of the benefits to success that we found was that although people within the clinical service were all located in different places, we all had great trust in each other and we all communicated with each other. And that was part of the success, really, was that it was hospital, community, people at home, but we felt like one team, even though we were in different locations. So the first step really in implementing a successful virtual ward was educating the clinicians within the hospital about what the virtual ward could do and who were appropriate patients to be referred into the service. And that was no easy task. That required a lot of leadership within the hospital to disseminate that information quickly. We then had a team of very experienced respiratory nurses who were quite used to discharging patients with COPD and other respiratory conditions, who helped to identify suitable patients. So they had patients referred to them within the hospital. They would review them, see whether they met the criteria for discharge. And this allowed us to kind of pick out people who we felt wouldn't be suitable, but also allowed us to push the boundaries a little and adapt our criteria if there was a good reason as to why we needed to. So we took home people on sort of very high flows of oxygen who'd been stable for long periods of time, and we constantly adapted our criteria in individual circumstances, but safely. We then discharged people from the hospital and onto the virtual ward. And then they were managed by a team within the community setting who called the patients on a daily basis to check in on how they were and to find out their oxygen levels. And then we had a daily consultant ward round with a respiratory consultant or general medical consultant to go through the patients, find out what the problems were, and solve problems as we went along. Some patients had to go back to hospital because we were concerned that they'd had a complication, but this was very small numbers. Most of the patients had a really good outcome and were discharged from the virtual ward at the end. And we had a couple of patients who deteriorated, and we were able to manage them in the community with end-of-life care rather than escalating back to hospital, which probably would have been the outcome if they hadn't have had high levels of supervision within the ward. So just to give you a flavour of our experience, our virtual ward had quite large numbers of patients go through it compared with other hospitals in the local area. In the first 7 weeks of the virtual ward, we took home 135 patients with COVID, which far exceeded our expectations and definitely put a lot of strain on our workforce at the time. It's always difficult to really show the definite impact of a service. So we undertook a detailed audit really of the first 135 patients to go through the service. We had a number of patients who were on no dexamethasone or oxygen, so 67 patients. We had a cohort of patients who were on dexamethasone, and in England, to be on dexamethasone, you either have to be an inpatient or on a virtual ward. So without the virtual ward, they would be in hospital. Again, we had patients who were on oxygen, and they were only able to be safely discharged because of the virtual ward. And then we had a small number of patients who were on both oxygen and dexamethasone. And we looked at how confident we could be in terms of the number of bed days saved in hospital. So we looked at if you were on dexamethasone or oxygen, we were saving bed days for all the days you were on those treatments. And we estimated we saved at least 616 bed days in the first 7 weeks of the service, which is a great deal of bed days, and enabled wards to be closed down from being COVID wards and changed back to being the sort of wards that they normally are, so orthopaedic wards and other types of wards, and started to allow normal services to resume within the hospital. Patients really enjoyed being part of the service. We had very positive feedback. People felt that they were well looked after, that they were supported, and they felt safe while they were on the COVID virtual ward. So all of this was fantastic, but we had neighbouring services where they used a much more telehealth approach. And what we could see quite rapidly in our service was that it took a great deal of workforce to be able to deliver this, and that we really needed to be looking at digital solutions to enable us to do this at a larger scale. So our neighbouring trust, they were doing everything on a telehealth platform, and it worked incredibly well. The outcomes were very similar in terms of patient feedback, patient safety, but they had much less resource required to be able to deliver that service. So the future really was combining those two together. So we found that the virtual wards were safe and effective, that choosing the right patients is key to success. We can definitely reduce length of stay. Having consultant oversight in an early supported discharge service really lets you be more flexible in terms of who you take home and allow more complex patients to go home. But actually, most of the patients had a fairly uncomplicated recovery, and telehealth could definitely be used to try to do this at a much larger scale. We weren't the only people harnessing digital technology and looking at oximetry at home to keep patients safe. In Paris, they had Covert app, which did very similar things to the UK oximetry at home, but that enabled patients to be managed at home, have their symptoms assessed, their oxygen levels assessed, and it enabled that triage of who could be safely managed at home, who needed to go to hospital. But because this was done on an app basis, they were able to collate data. And so it's been very useful then going forwards, looking at what are the longer term complications and the longer term outcomes from COVID. Similarly, in other areas, so Italy and Switzerland, they've had a Como service looking at telehealth monitoring of patients with COVID. And they were much more futuristic than we were in England, in that they looked at how you manage the individual patients, but they were also looking at using that data to inform what was going on a sort of larger scale, and also helping to create the services for the patients and look at longer term outcomes. So we got lots of things right in England. We implemented things quickly, but we didn't really harness digital data to the maximum because we had lots of little different pockets of work going on. We've got lots to learn, but we're looking to the future. So lots of people now are bought into this virtual ward model, and really, there's possibly two ways of implementing this in the future. You can either go with an acute syndrome pathway, where you look at symptoms that patients present with. So you could look at patients presenting with breathlessness or chest pain or abdominal pain or something based on just symptoms, have a clinical assessment, and then put them through into a virtual ward model. Or you can go on a disease-specific pathway, which is what we've chosen to do in our local area. I think that's more straightforward to implement when you know what somebody's diagnosis is. So you can look at COPD, you could look at heart failure, talking about working with our cardiology colleagues. We can look at asthma, bronchiectasis, pneumonia. Those are the sorts of conditions that we're looking at. People deteriorate, and then you can have them assessed and either manage them in the community, have them go to hospital, and then triage them into who needs hospital care, who needs primary care supervision, and who needs specialist supervision in the community. And we can have a very integrated approach with a tiered model, using one digital platform but having different clinicians overseeing care. So in Cheshire and Merseyside, where I work, we have a vision for telehealth, it's part of the digital strategy for the area, but it's really a clinically led programme supported by digital technology rather than digital technology that we're trying to slot into. And we're considering it as a pyramid approach, where you have at the lower end of the pyramid, we will have telehealth and app-based support for patients with long-term conditions, and that they can be very much self-guided, so really focusing on supported self-management. In the middle, we have people who are at slightly higher risk, who need support from community teams and primary healthcare teams, but can use digital health to support that. And then at the top end of the pyramid, we have the patients who require either admission avoidance or early supported discharge. And they will be overseen by specialist teams so that we can give them the right clinical expertise to keep them safe at home. The plan moving forwards in our area is that we're going to have a combined COVID and respiratory virtual ward model, harnessing all the learning from the service at Wiston Hospital, which was very much clinician-led, and with clinicians in the hospital and clinicians within the community managing the patient, but adopting the telehealth platforms where we can manage large numbers of patients through telehealth and make sure that the right patients get the right level of expertise. So if patients are doing very well, they don't need consultant respiratory physician input every day, but the patients who are getting complications or having problems do need that high level of supervision. So we're starting off with COPD because we have COPD pathways in place at the moment, and then we're going to move next into bronchiectasis and community acquired pneumonia, and then finally asthma over the next 3 months are going to get added into our virtual ward. So it's very much a live process going on at the moment, and it's something we've wanted to do for a long time, but it's only been made possible because of COVID, so that people have now seen that we can put digital platforms in place very quickly, that we can safely manage people at home. And it's really allowed us now to look at the transformation of services in a very positive way off the back of the learning from COVID. So I feel we're in a really positive place now where we can put the last year of trauma for everybody behind us and start to look forward to a better future where we can take all the good points and the learning that we've had. So thank you very much for asking me to talk, and I'll be happy to answer questions later.
Thank you very much, Sarah, indeed. And thanks also for sharing your personal experience around digital health. And I'm sure that in 10 years, we will look back at this pandemic as the moment that changed healthcare forever. Before introducing the next speaker, let me just remind you of the poll that is currently going on just below the video that you can see on the main platform. Can I also ask you to ask your questions in the Q&A section over there, and that will then entertain the further discussion for today. Looking at the poll results, it looks as if overall the experience with digital during the COVID pandemic has been quite positive, so that matches up quite well with Sarah's story. But now it's time for our next speaker, and that is, I'm really delighted to introduce to you Professor Sally Singh. Professor Singh is working in Leicester, and long before we had the COVID pandemic, she already started to bring pulmonary rehabilitation to the living rooms of patients so that more patients could actually engage in a pulmonary rehabilitation program. Then obviously the COVID pandemic accelerated, as we heard earlier, the rehabilitation done remotely. And so Sally, it's really a joy to hear you give your presentation on telerehabilitation with and without COVID.
Thank you very much, Thierry, and it's an absolute pleasure to be part of this symposium today. So do I need to wait for my first slide, or do I? Here we go. So as Thierry indicated, I've been asked to talk about virtual rehabilitation, both in the context of pulmonary rehabilitation and, of course, the new and emerging challenge around COVID. And in relation to this talk, I have no conflict of interests. So I'd like to use this slide as a marker for the next 15, 20 minutes or so, just to give it context. And of course, pulmonary rehabilitation was largely provided in hospitals or centre-based rehabilitation programmes, and I'm sure none of you need reminding, but it's particularly focused on individualised exercise programmes that are individually prescribed and progressed, and we believe that that is at the cornerstone of a successful rehabilitation programme. And of course there have been some home-based programmes that have been digital or not, and of course COVID came along and really forced us to rethink how we were delivering rehabilitation, not only for the patients with COPD, but of course, as I'll show you later, we've been challenged around providing rehabilitation for that COVID population. So this is what I'm going to be focusing on for the next few moments. Could I have the next slide, please? So just to give some context around what was happening pre-COVID and reinforce this earlier statement that the majority of programmes are indeed provided in centres. The graph on the left-hand side is data from about 40 countries and published back in 2014, so open to criticism with respect to digital engagement. But on the right-hand side, we have data from the UK that was published last year. And that is representing over 12,000 cases of pulmonary rehabilitation. And it's quite startling that nearly 98% of patients were offered a centre-based rehabilitation programme. But 34% of services did report that they offered home-based rehabilitation programmes. We didn't ask whether that was telephone contact or manual-based or indeed digital, but actually a very small percentage of patients took up the offer. So there are real challenges, and we heard Martin talk about digital engagement of both staff and, of course, patients. And this is some data taken from a waiting list at the beginning of the COVID pandemic. And you can see that patients' overriding expectation or anticipation and hope was for a hospital or a community-based programme, and very few felt that a manual or a web-based programme would be appropriate. But what's interesting, and what you must bear in mind, of course, is this population had been referred in to a centre-based rehabilitation programme, so perhaps their expectation was not to take part in a digital programme. On the right-hand side, you can see if people were to engage in a digital programme, perhaps what elements they would be amenable to. However, there has been efforts to help the rehabilitation community to define what a rehabilitation programme comprises, irrespective of the intervention, if you like, that forms part of that rehabilitation sandwich, where we have a very comprehensive patient assessment at baseline, which you can see identified in green. And then the programme components that were identified through this Delphi process were agreed to be endurance training and resistance training. And importantly, as I'd already quoted, that the exercise programme has to have this individually prescribed and progressed package. But what we didn't define was where that programme had to be delivered. So irrespective of whether you're delivering a digital programme or a home-based programme with a manual and telephone support, these are the components that you should be delivering. And importantly, and I can't reinforce this enough, is that the healthcare professionals have to be trained to deliver the model that you're deploying. We've talked about health literacy in staff, and if we're going to deliver digital platforms, they have to be trained and competent and comfortable in delivering that. However, delivering digital or rehabilitation programs is not new, and I love this study, and it was first published back in 2008. Very simply used an old-fashioned mobile phone, not a sophisticated smartphone. And they asked patients to perform an incremental shuttle walking test and then identified the speed of walking that would be appropriate for them to have an individually prescribed and progressed training program. And then they uploaded music onto the telephone that was at that appropriate pace for that individual. And you can see this graph in the middle that clearly those patients that had this telephone-based intervention really got striking improvements in their incremental shuttle walking test distance, whilst the control group didn't. And there were improvements in their health-related quality of life as well. So digital interventions aren't new. I think we've been quite slow to adopt them. This is perhaps one of the more recent interventions and something that we've already been talking about this morning, which is telehealth rehabilitation. And certainly during the COVID pandemic, there have been a number of efforts across Europe and the States to try and support patients remotely. One of the challenges has been the absence of an initial assessment. So arguably it's not rehabilitation, it is some form of supported self-management. This data describes a tele-rehabilitation programme that was conducted in patients with severe respiratory disease, but was a fully powered trial. And patients who were willing to be randomised either to the telehealth intervention or conventional rehabilitation followed the respective programmes. Now, interestingly, you can see their primary outcome measure was the CAT, so a health-related quality of life measure, and there was no significant difference at any time point for the intervention, either immediately after the intervention or indeed at follow-up. Similarly, you can see there's no difference in the 6-minute walking test distance or physical activity. I think this is an interesting study. Not least because the rehabilitation itself didn't seem to have a huge impact. So I think there is still a lot of work to be done in this space, but early data is perhaps not as encouraging as we might have hoped. And there's been some novel technology, and I think that we will be seeing a lot of this as we go through the COVID pandemic, and I think it's great to have our minds stretched and challenged in this way. The top data shows you results from a feasibility study looking at patients essentially engaging in something like a Wii Fit or a home gaming station. I'm slightly anxious this lady's on something that looks like a wobble board, so I think there are issues around safety for these home rehabilitation programs. And there's some qualitative data and early outcome data in this study looking at virtual reality. So patients in Cumbria, which is a rather remote part of the UK, were engaging in a home-based rehabilitation program with virtual reality headsets. Again, I would be concerned around safety, but I think if you can get over those barriers, it's a really exciting use of technology. So I'm now going to move on to COVID and rehabilitation. And I don't really want to rehearse the challenges that patients post-COVID face, but just to remind you that they are presented with an enormous array of symptoms. And this is data from the post-COVID study from the UK, where we are following up all hospitalised patients. So just to bear in mind, this is hospitalised data. So from this large group of patients, we can see I've just taken data from the FACIT, which identifies these patients at 5 months. On average, they were followed up at 5 months, so are reporting really quite significant fatigue. And this is data from their incremental shuttle walking test. And you can see that this is percent predicted that all groups of patients, and these are categorised depending on the level of intervention that they had in hospital, through from sort of minimal support through to intensive care support or other organ support. And you can see that really there is a marked impact in their functional ability. Now, what's interesting for the UK data compared to some of the other cohorts that have very recently been published is that our cohorts had a significant number of comorbidities, and a high number of patients had at least 2 comorbidities, which you would imagine would impact on these symptoms that are reported. But interestingly, even at 5 months, patients were reporting a huge number of symptoms, suggesting that there is a real need for rehabilitation to help them get back to where they were. And what's interesting compared to pulmonary rehabilitation is that this group tend to be younger than we commonly see in rehabilitation. So you might imagine that they have challenges of returning to work that we don't conventionally see in either pulmonary rehab and largely not quite so much in pulmonary rehab either. On the right-hand side, we've looked at our data for the hospitalised population to try and understand what the demand for rehabilitation might be. And we telephoned patients at the point of discharge and then followed them up again and asked them if they felt they had a perceived need for rehabilitation. And ultimately, that is how patients are referred in from their physician for COPD. You know, they complain that their MRC score is reduced, etc. What we found is, after this sort of flowing through this consort diagram, that if we'd sort of taken out all of the patients that were removed because they were being referred back to a nursing home or were very frail, through to those that felt they'd recovered, we think that from the hospitalised population, the demand is going to be about 25% of our denominator, which is a huge number of patients to manage in the absence of any really clear rehabilitation pathway. And it seems to have fallen to very commonly pulmonary rehabilitations to manage this demand. And you might imagine that we're going to have to engage with digital platforms to meet this demand, not only to meet the demand, but also meet the expectations of the population, because they are younger and one might expect that they are slightly more digitally competent and confident than those that we see within our pulmonary rehabilitation programmes. So in the UK, NHS England invested in a platform to support patients with symptoms post-COVID, and the site is called Your COVID Recovery. It has a front end which is publicly available for all patients obviously around the world, because it's publicly available, and has sections on many of the symptoms that patients are confronted with in the weeks after their infection. We've just looked at the data from the hits from the website, and a few weeks ago, this is the data, and it's changed a little bit, and I'll talk you through the changes in a moment. But you can see, perhaps not surprisingly, that the majority of hits are around fatigue, musculoskeletal issues, cough, taste and smell, shortness of breath, etc. So we were quite surprised that MSK was represented quite so heavily, because that's not consistently reflected in the data from the follow-up studies, but we wonder whether that's conflated with fatigue and muscle aches. And you can see that the majority of hits come from the UK, because that's, of course, where it was from, with a number from the US and India. But over the last few weeks, we've seen a significant drop in data hits from the UK, and a huge increase in the number of hits from India, which, not surprisingly, reflects the burden of the pandemic in each of the respective countries. So in terms of digital health for patients really struggling to recover from COVID, there's really not very much data. There is some data around face-to-face rehabilitation, which early indication would suggest that it's safe and effective, but most of this data is cohort data. So we have to treat this data cautiously. But I'm just going to show you some of the early digital interventions for patients post-COVID. And this is a study from Italy, where patients were recruited immediately post-discharge and were offered a telehealth intervention with physiotherapy calls and daily monitoring by a nurse. And they had an enormously high completion rate. I mean, that is really impressive, to get 24 patients adhering to a digital intervention out of 25. I mean, that would almost be unheard of within the realms of pulmonary rehabilitation. But you can see by the graphs on the right-hand side that there was improvements in 6-minute walking test and breathlessness, sit to stand, and you might expect some of these changes because of natural recovery. So I think, there will be some debate as to where we best place the interventions for patients and how we offer those. So it may be that these patients will get some natural recovery that you might expect, and that's certainly what you would see in the ITU literature. So I think that, there's very much an open field in terms of where this is best placed and for how long it is delivered for. But I think it's really encouraging that it is feasible and patients seem to engage with it, which is reflected in the remarkably high completion rates. So in the UK, we've also developed a platform for patients that are really struggling to recover. So we have phase 1 of Your COVID Recovery that is open access for those in the early phases of their disease. And if patients don't recover, we've developed this platform to really support patients on their journey to recovery and ideally back into the workplace. So this was developed by a consortium of people from across the UK that have expertise in many of the areas that have been noted in COVID, and that extends way beyond pulmonary rehabilitation. So we had experts in fatigue, sleep, taste and smell, musculoskeletal, pain, speech and language therapists to support people around swallowing, etc. So one of the joys of COVID is that it's this collaboration that we've heard so much about. So this group would get together every week and develop the content, work with patients to develop the content, and really at pace develop an interactive platform for patients post-COVID. So this is broadly what the patients might see when they land on the website, and it has a focus on goal setting, and then the resources match the individual's goals. And you can see on the right-hand side the array of information and interactivity that is available on the site. We also collect patients' symptoms so that we, as therapists or nurses or speech and language therapists or dietitians, who is ever delivering this system, can look at the back end and understand how the patients are progressing. They can also email in. So it isn't a synchronous platform, it is an asynchronous platform. There is no scheduled webinars within it, but patients can email in and have direct access to their healthcare professional. So patients do need a degree of digital literacy to be able to engage with the site, and we would assess that in terms of their ability not only to take part in this intervention, but also whether they could shop online, for example. And then there are trackers, particularly around people's activity and mood. So there is a focus, again, on activity and regaining functional capacity. But of course, it's really important for all digital interventions that we have a process of shared decision making with patients. And I don't think we've really explored this particularly well within the field of rehabilitation, not least because digital platforms aren't as highly evidenced as centre-based programmes. People that work in centre-based programmes are very wedded to them, and their openness to adopt other programmes may be limited. But I think if we're going to take this forwards for the COVID and all other populations, we really should be open to engaging with patients and allowing them to make an informed decision as to which intervention might suit them best in terms of the clinical effectiveness of that particular intervention, but also how it may fit within their lifestyle. So I think that this is an area that we all need to develop and have some commitment to. So in summary, I think the COVID pandemic has really promoted the development of digital models of pulmonary rehabilitation, but I do think the evidence base needs to be strengthened. Thierry mentioned that we've spent a lot of time developing web-based platforms for patients with COPD, but until the COVID pandemic, uptake was remarkably low. And centres have certainly adopted other models and engaged with us to develop their offering of both web-based cardiac and pulmonary rehabilitation. But I think there is a lot of work to be done there. I think there are challenges for services to accommodate the post-COVID population as well. But I do think services need to accommodate personal preferences for the individual if we are really going to increase the scope of the programme. And I think research is always needed to develop these digital interventions to support symptom reduction and behaviour change in this population. Thank you.
Thanks very much, Sally, for a great overview on this topic. I'm going to do the question and answer session now together with Anita. So, Anita, I don't know if you had already some questions for Sarah.
Yes, I do. Thank you very much. I have 3 questions that we'll discuss with Sarah, and then we'll hand over to you to talk through Sally's questions. Sarah, thank you so much. What you showed was wonderful in terms of breaking down barriers between the hospital and community primary care, and breaking down barriers within the hospital with the emergency room teams and with paramedics and so on. That was wonderful. You described what work you're going to do next and how to really develop your service. I remember as a trainee various hospital at home schemes that were developed with great enthusiasm. They were adopted for a while and then they fizzled out. And I wondered what you would do to embed all you've learnt on the virtual ward to ensure that it is sustainable.
Yes, so hospital at home schemes are quite varied across the country, and certainly across the area where I work, there's quite wide variation. The hospital that we've based a lot of the work around has 4 different hospital at home services that support patients out, all with different referral criteria, different levels of support once they're actually discharged from hospital. And it's hard to embed something when there's so much variety and postcode lottery involved. So what we're trying to do now with the virtual wards is in every hospital have essentially one service for the hospital to access rather than multiple services, and allow us to harness telehealth so that we can be more cost effective with the use of our workforce, so that we can take home more patients with a wider variety of conditions. Most hospital at home services really focus upon COPD, but if we can be cleverer with the use of our workforce, we can actually expand that to allow us to support home people with a whole variety of respiratory conditions.
Thank you. That makes a lot of sense. There's a top question that's come from Pakistan, which is really talking about the use of these virtual ward services in rural areas and conflict zones. I think what I might say is that we have a presentation tomorrow morning from Dr. Falzon from the WHO, who's going to talk about use in low resource settings. So maybe we'll leave that question to then. We also have a question coming from Italy about early alert at home services. So people at home and then avoiding being seen in the emergency room to avoid their getting infection, avoid them coming into hospital. Is that really similar to the GP-based practice that you used, would you say?
Yes, it is. So at the beginning of the pandemic in England, there was a very strong stay-at-home message to everybody. So which was probably too strong, and a lot of people sat at home with quite serious other medical conditions apart from COVID, and also sat at home with COVID illness deteriorating without seeking healthcare because they were told, it's your responsibility to stay at home. So the community and primary care led COVID oximetry at home really helps you to triage the population outside of a hospital setting to ensure that the right people are accessing healthcare and people that are safe to stay at home do stay at home. So it's really a combination of admission avoidance and early triage and early identification of people who are unwell. There are quite a lot of logistics with disseminating the pulse oximeters to patients. But Matanada Kim, who's been leading this work nationally, has done quite a few presentations on doing this in areas where resources are extremely stretched, and you can really give the patient the oximeter, give them the information and allow them to self-direct the monitoring without having to have a lot of extra resource.
Okay, interesting you mentioned oximeters, because there's also a question on the type of oximeter you used. One can get really cheap oximeters for €10 or so. What was there anything special about the oximeters?
No, so the NHS managed to procure about 700,000 oximeters to support this work across England. So they really helped to make sure that purchasing oximeters for patients wasn't going to be a barrier to having access, but many patients also purchased their own oximeters as well. So we just asked that they've got a little CE mark on to show that they've been appropriately tested. But there was a whole variety of oximeters used. Some of them actually haven't been of a high standard, so we've had to have quite robust alerting systems to sort of highlight when oximeters aren't of a standard that we'd expect.
Okay, so I'll hand over to Terry now for some questions, and then we'll see how we go with the timing. Terry.
Thanks very much. Thanks very much, Anita. We had some interesting questions. One from Professor Enrico Clini, also from Italy, where he asks if there are persistent symptoms after COVID-19. Does that mean that a patient needs rehabilitation? Can I perhaps make that question a little bit broader and ask Sally, how would you screen for rehabilitation to begin with? And perhaps then follow up with how would you screen for telerehabilitation? Is this a different brand of patient, or should all patients be eligible for telerehabilitation?
So I think that's an interesting question. In the UK, we have a system where patients are referred into a post-COVID clinic. And so any outstanding medical issues that need additional treatment or investigation are managed within that clinic. And then if we believe that there is nothing that needs any additional treatment, because like Sarah was saying, not only patients have had COVID, but if they have a variety of comorbidities, then they may have got better or probably a lot worse during COVID. So all of that needs checking in the same way that it would for pulmonary rehabilitation, to make sure that an individual's is medically managed. And then we would invite patients for an assessment, which is not dissimilar to a pulmonary rehabilitation assessment, but there is much more of a focus on fatigue and measurement of fatigue and consideration of post-exertional malaise in this population. In terms of digital health, our assessment is no different. Interestingly, we know that this Your COVID Recovery has been rolled out to about 100 centres across the UK, and not all of them are rehabilitation centres. So their anxiety, if you like, about doing exercise tests is different. And so we, as a team, alongside NHS England, have suggested to do at least a 1-minute sit to stand, so that we have an understanding of the level of desaturation, notwithstanding the limits of a sit to stand test to pick up desaturation, but it's better than nothing. So I think that we're definitely learning, and different people have put in different models of assessment, some much more light touch than others. Within the platform, we have the EQ5D and the COPD assessment test, so the CAT score, which at the very beginning of the pandemic, we looked at the use of the CAT score in patients with COVID, alongside Paul Jones, the original author of the questionnaire.
Okay, thanks for that. And can I perhaps follow up with another question on perhaps some guidance for researchers in this field, and how do we evaluate properly the effectiveness of these telerehabilitation or other digital interventions? And we're used to looking at clinical effectiveness and to see what effect a program has on health-related quality of life, or the 6-minute walking test, or other exercise tests, muscle strength, and so on. Should we perhaps here also learn to take on board measures of uptake as an outcome measure of a trial, perhaps settle for slightly less clinical effectiveness, but much better uptake? I think this is a discussion that we see appear in the literature, but also in clinical practice.
No, I think that's absolutely right. And, we're in danger of offering a few people a sort of Rolls-Royce service, when actually we could offer a greater number of patients, a less than perfect service, but less than perfect is probably still good enough for a lot of people. I think we always have the debate in rehabilitation fields as to how we define adherence and completion. And I think one of the advantages of digital platforms is that you can absolutely directly measure engagement in a way that is more difficult in face-to-face rehabilitation programs. I think the trial design is challenging for digital interventions, because traditionally, as I spoke about, we assume in randomized controlled trials patients have to be willing to engage in either or and be happy with that choice. But I think in real life it's much more likely that patients will have a preference for which path they follow, for a variety of reasons. So I think that we have to rethink trial design as well, and look at preference-based or choice-based trials, and then, like you say, Thierry, really look at implementation, because I think some of the challenges are anxieties within the staff that are delivering these programs, in terms of their digital competence to have a fair discussion with a patient as to whether a digital platform is right for them, and their personal confidence in managing the back end of the site. And we've certainly seen that. So I can't imagine we're different to many other centres.
Mm-hmm. Yeah, and there's another question coming in on how to manage aerobic exercise in telerehabilitation, and perhaps also broaden up that question. How do you make sure that you still adhere to the basic rules of training, progressive overload, and so on? And of course also safety. And while I do think that there are also excellent programs, tele programs for hip fractures, we try to avoid those in our patients, of course, and make sure they don't break a hip.
Yeah, I think it's interesting. We, before COVID, did a quite, well, I thought it was quite a sophisticated study where we tried to look at the data from an activity monitor to make sure patients were walking at the right speed. And then we would represent that back to them to say that, yes, you're walking at the right speed because they'd worn it during an exercise test. So we could calibrate the data from the wearable with the data during the program. But that, whilst it seems immensely attractive to be able to monitor exactly what patients are doing, I don't think that the systems are able to do that and give us feedback at the moment. So I think it's difficult to progress that, I think, on a large scale. I think there is the scope, but it's tricky, particularly in people that have limited exercise capacity. So I think that we have to, do the methods that we use conventionally in rehab, calibrate it against people's breathlessness, look at the time that they're walking for, and check in with them regularly to see how they're doing. There's no easy way around that at the moment, because I don't think we can expect people to buy Fitbits, and I'm not sure that our health service are going to, and of course other brands are available, but I don't think that our health service is going to go that far. They might buy a pulse oximeter, but not at the moment wearable technology.
Mm-hmm. Yeah. And if I may sort of bring the presentation of Sally to the presentation of Sarah, then Sarah, how flexible was the system that you used, and would it be possible to hook on a rehabilitation module to the system that you used, and go back to my Lego analogy, where it becomes then a bit more complicated, but still patients keep operating within a framework that they know, that they're familiar with, and that also the healthcare professionals know and are familiar with?
Absolutely, and we've definitely learned that we missed a trick here in our area, that there's a lot of things at COVID oximetry at home, COVID virtual wards, and then long COVID, and then we've missed a whole cohort in the middle that are in primary care starting to recover. So we're now taking a step back and looking at the whole end-to-end process, right from when you first get COVID to the end of a sort of long COVID journey, and we're investing in one telehealth product so that people will be familiar with the technology, familiar with the apps, and you can get a number of wearable devices with that. So it's about matching the level of supervision, the type of device that people need, with what their clinical need is, but using a platform that runs across all areas. They don't have to keep relearning how to use technology.
Excellent. Anita, back to you then to wrap up the session.
Well, thank you. I think we've learned a lot. It was really nice to understand about the integration at the end. We've had lots more questions, but we have reached our time limit now. So I'd like to thank Sarah and Sally and you, Thierry. We're going to go to a short break, but we'll be back very soon for our session on wearables and apps. Thank you.